All right, everybody, it's Mrs. Ransell. As promised, I am just adding to some of the things that I think we glanced over in lecture rather than getting into more detail. So just want to hit some major points as you're finishing your studying for your exam too. One of the questions I received from one of the students was, what was the purpose or point of the red reflex? So just to clarify, using that ophthalmoscope or to shine the light through the eye, um, your pupil should be able to reflect back the fundus or the back of the eye because the lens is clear and there's no obstructions because of tumor or anything of that nature. That being said, I should be able to have that red reflex. It should flash back at me as the observer because everything's clear and straight through. Okay. So I should be able to see that in both eyes with no problem. So remember what we talked about, that red reflex. You're able to see it in both eyes with no difficulty in the event that there's no blockages or obstructions. If we have a white light shine back at us, remember that could be related to a cataract. If we have nothing, we can have a true blockage due to a tumor or a retinoblastoma. Okay? All right. So let's move on to the next slide. All right. So let's talk about hearing, because that's one of the things that we wanted to make sure that we were able to not just glance over, but just give it a little more detail for you guys. All right. Sound moves through the air in the form of vibrations. These vibrations hit our tympanic membrane, the eardrum, okay, and then move into the inner ear. They're processed when they are in the inner ear through small bones, ossicles, that are inside that inner ear. One of them in particular that's very impactful to our hearing is the cochlea, which is directly connected to the auditory nerve or vestibulocochlear nerve, that's cranial nerve 8. And then the brain is able to interpret the sound or the vibrations, and you then hear something. Okay? All right. So when you're looking at, and I'm going to go back one, Weber as an assessment of hearing. I think I want to do something else. Hold on one second. Okay. Just using the slides in the order you guys had them. That being said, when you are listening, when you are hearing or perceive the sound we hear, that's when everything is working perfectly according to the anatomical plan. Vibrations come across the air. We then can perceive them as they move through the ear canal. They hit the tympanic membrane, go through to the inner ear, and then are processed up to the brain through the cranial nerve 8, vestibulocochlear, or auditory. If we have challenges related to anything that stops the vibration from hitting the tympanic membrane, that is what is considered a conductive hear loss. Conduct, to move through, just like a train conductor moving you through something, okay? It does not move through the challenges. We can't get the sound to the tympanic membrane, okay? And there's a variety of reasons why that happens, but some of them have to do with hardening of the tympanic membrane due to infection or any problems you have with the ear canal or the eardrum, okay? Sensorineural hearing loss is just that, sensorineural, sound to brain. The vibrations can travel through the canal, but they don't get processed up and through. Okay. And there's a variety of reasons for that, but some of them include damage to the hair cells that help flip or move the vibration up and through the inner ear, and then or damage to that cranial nerve 8. So I then can't process the vibration up through my brain. And obviously mix will be a mixture of the two. Okay. All right. So sorry for going back and forth. That being said, Weber and Rhine, or Renee, remember I told you guys I never remember quite how to say it. That being said, Weber and Rhine are useful tools. They help us assess hearing, okay? Weber, remember, you hit the tuning fork, you put it right there at the midline of the patient's head. Because we know that there are bones in the inner ear that help us process through these vibrations, though that vibration going through the head allows us to assess the ability of the bones in the inner ear to process vibration, okay? We should be able to hear the vibration or perceive the vibration clearly through both ears, okay? So if we can't do that, then we can become knowledgeable about whether our client is having a challenge in one ear or in both, okay? Or no challenge at all. The Rhine compares the bone conduction, which we just talked about, to air conduction. By what I need you guys to understand is two things. The vibrations in the environment, sounds as they were, are coming over the air. So it would make sense to me, and probably to you too, that air conduction or moving over the air is going to be greater than what is moving through the bone. Okay? So that test, you strike it, the tuning force, place it right on that mastoid bone right behind the ear. You're recording when the patient hears the sound and when it stops at the ear. Right away, you move it right up to that auditory canal. And then you record again when the patient has said they hear it at the auditory canal and then when it stops. Comparing the two, we should see that you hear the sound longer at your ear rather than perceiving it through your bone. Okay? All right. Just making sure we had that squared away. All right. We went through that. Sensor, let's focus in more on the sensor and neural hearing loss. Sensor and neural, sense, neural, brain, to the perception of the sound to the brain. So when we have a loss of the sensor and neural, there's a variety of reasons how that can happen. All right, so in your text and also on this presentation, you see ototoxicity. Oto, hearing, toxic, to kill the hearing. There are certain medications that you see on your PowerPoint which can kill those things that support your hearing or damage them. A lot of the damage occurs to the small hairs that help process the vibrations through in the inner ear. I just want you to pay attention that NSAIDs, NSAIDs, things like Aleve and Tylenol, things of that nature are contributory to ototoxicity, depending upon how much you use them. So just be mindful of that moving forward. But then there's things like acoustic trauma of sound. We put ourselves at risk for it. So then occupationally, if you work in construction or someplace where things are banging and booming, you do understand that some of those things are going to come with as an occupational risk. But then there's also personal choices, like the way we listen to our music through earbuds, which are directly jamming the vibrations into or past our auditory canal right away and vibrating right into our bones. So we can damage inner ear structures and those fine hairs that help the vibrations because there's so much sensation coming through. Additionally, playing loud music in our cars, going to concerts without earbuds, going to loud and closed environments like nightclubs where the music is thumping. Please note when you come out of a club or something like that, your ears sound like they're in a haze because of so much sensation that your vibrations that your eardrum and inner structures have had to process. There are diseases that can impact your the ability to translate vibration into sound. Some of those are a major one is hypertension. Okay, so just being mindful of that. And then there's presbycusis. Okay, that's gradual hearing loss that happens in our older adults where what you hear is muffled. What you hear is muffled. And it's a gradual loss of hearing that occurs in our older adults. Now, and I'm just looking at your slides as I go through. Gradual is the optimal word. It doesn't happen overnight. Okay? Because it's related to high frequency loss. There's missounds of F, G's, L's, T's, and S's because if people speak quickly, like I sometimes do, it will be glanced over and people will lose what you're saying. They cannot hear it. They cannot perceive what it is that you're saying. So as we speak with our older adults, as you go to clinical, as you work with your client base, please be mindful that you're not yelling or shouting with any client of any age range. We want to speak at a clear and reasonable pace. We want to speak loud enough to be heard. We want to eliminate background noise when we're trying to speak to our clients. And we're never going to shout at them. We just need to speak clearly so everyone can understand us. All right. Other conditions of the inner ear that you may observe in your clients moving forward, or things for you to know about. Vertigo. Inside the inner ear, be mindful that there is a fluid balance in there. Remember, we talked about how to keep something level. Our level has that little liquid in the inside that's on the line. That's how we know how something's straight. Similar processes happen inside our ear, inner ear. As such, if there's anything like an infection that throws off the amount of fluid volume inside the inner ear, we have an overload of fluid, we could have challenges with understanding where we are positioned in the world. As such, that's considered vertigo. Okay? People who have vertigo, think about spinning around and then stop, closing your eyes and stopping really quickly. There's sometimes nausea associated with that condition. People feel very disoriented. So just be mindful of that. Vertigo is positional, and my body cannot understand where I am positioned in the world. Okay. And it occurs in response to the change of position. So that means we want to work with people to not get up or jump up quickly. Okay. Everyone should take their time when they're rising or changing position. Meniere's disease, vertigo, tinnitus, the ringing of the ear, and sensorineural hearing loss. Remember, that's that sense neuron, sense in your brain, ability to process the vibrations through the inner ear. Okay. And it's episodic. So it comes and goes. It could come for some time and then go, or it can come for an extended time and then go. But we cannot rate or pace it. It's individualized. So for your client, remember, they want to stay in a quiet and dark room. We need to think about safety with them, remember, because the vertigo is involved with that. So they actually cannot perceive where they are in space and time. Diuretics, remember that fluid, that inner ear balance, there's some fluid involved. So we're going to try to drain off any extra fluid that we don't need. We're going to drive them out through antihistamines and calm them down. Okay. Calm them down. Calm them down. Remember, caffeine and nicotine create anxiety. We'd already be anxious enough if you were suffering with Meniere's disease. Last thing, labyrinthitis, one of the inner bones. Those inner ear processes, it's caused by an infection. It inflames the system. Again, impacts where people understand they are in place and time. And we just need to make sure that we are following those treatments we use for Meniere's disease with labyrinthitis. All right. Care for our clients that have any sensory deficits. So we talked about the neurological system, we talked about the eye, and we talked about the ear. Understand that these are part of our core senses, how we perceive the world. In the event that you cannot see or hear or perceive anymore, you don't feel as safe as you used to. You may actually need assistance to move through space and time or participate in activities of daily living. You may lose one of your joys if you like to listen to music, or you like to paint or visualize or view sunsets. If particularly you're losing vision or hearing, a sense of isolation can come over you because I don't feel safe enough to move through spaces and places, or I can't do what I used to do. Okay, so I'd rather stay here in place. I may be confused, and overall the quality of my life will change.